Our second speaker is Professor Christian Rolfo, and Professor Christian is the Director of Clinical Trial Management Program Oncology Department at the University Hospital of Antwerp, and he's going to speak about the biomarkers beyond PGL1 for immunotherapy, TILS, TMB, and others, the way for patient selection. Professor.
Thank you very much. Thank you, Professor Ghaffar, for the introduction. It's a pleasure to be here, and I would like to thank the organizer and Dr. Al-Ghazali for the invitation. So several of the things that we will discuss today were perfectly discussed by the former speaker, and I would like to focus a little bit in the PD-L1 status and the next kind of target that we can select our patients in the better or in the proper condition. So that are my disclosures. So we know, and it's almost in a majority of the tumor. My focus is lung cancer. I will orient the speech in lung cancer, but it's very known that PD-L1 is a predictive biomarker for response. So several meta-analyses were performed in that setting. We know that the PD-L1 is, like Professor Al-Ghazali say, is a very easy to search in immunohistochemistry. We know nowadays that it's also a prognostic biomarker, at least in lung cancer, because some of the data suggest that this PD-L1 expression is associated with a worse prognosis. But this is the dilemma that we have when we are treating cancer patients. The majority of the oncologists, especially in lung cancer, we have an important number of drugs that are coming, but we don't know how to select our patients, how to select the best, the faster, and the deeper responders. So we need biomarkers, and we are habited in biomarkers like target therapies that are really easy and practical to measure, like EGFR, for example, are present or absent, are 100% predictive, but in immunotherapy, that is not happen. So it's completely the different situation. We are working here in immunotherapy in a binary or versus a biological continuum system. So if you look, for example, this first part of the slide is what happened with the target therapies, EGFR, ROS, ALK, all these kind of target therapies or are absent or are present, and we can have there and a benefit for our patients. Here, like also the chairman say, we have different scales of grids that we are looking for our patients according if they are positive, the percentage of the positivity, and this percentage of positivity is also related, at least in first line, with a good response for our patients. But there are several problems that we are facing now with PD-L1. The first one is that there is the intratumor heterogeneity. This is a case you see in part of the slide. The first part is a completely negative part of the tumor. In the other part is a completely positive. And you have the same in the intrapatient heterogeneity. So some patients have, like this is the case, and we know that several of the lesions that we learn are from melanoma. So you have here a primary melanoma that is completely negative, and lymph nodes that are positive, and a brain metastasis that are wake positive. So this is a very important problem. In addition to these problems of the interpretation, we have the monoclonal antibodies that we are using that are completely different between each other. Several of them, several of them have an accompanying diagnostic or at least a monoclonal antibody that is more suggested to the interpretation. In the interpretation of one of them, this is the case of atezolizumab, we have an important difficulty for our clinical practice, that is to check what happened in the tumoral cells and in the infiltrating cells, and we need to have there a score that is very difficult to interpret in the clinical practice for all the oncologists. In order to have an homogenization about this situation, ILCLC, the International Society of Lung Cancer, tried to get a consortium and a homogenization study that is the blueprint. And in this blueprint analysis, the majority, if you look in the part of the slide that is here, the SP142, that is the atezolizumab monoclonal antibody, you see the concordance is very low compared with the others. So that was the conclusion of the panel. And actually in the blueprint 2A, that is an experience in the war, real life situation, so you have there the same conclusion. So we have still some problems. One of the idea to have some results combining the monoclonal antibody for the same biomarker, for the same drug, for example. That is the case of atezolizumab. These data were presented by Gadgel in ESMO this year, and you see that they tried to find the same proportion of patients that are positive or negative according to the different monoclonal antibody. And even if this is an initial data, they suggest that there are concordance, but we need to be very careful with this data still. Which other biomarker we are using for predict the best response to our patients? This is a very old slide, and everybody knows that about the mutational tumor burden, and you see that there are actually, if you look this slide, all the approval by FDA following this schedule, so melanoma, lung cancer, bladder, and so on. But it's important to have mutational tumor burden. You see, this is the trial that was in first-line negative. Nivolumab checkmate 026 was negative, but when we applied this mutational tumor burden, you have an improve in the data. Actually, if you combine PD-L1 expression and mutational tumor burden, like in this case, here you have an important number of response rates. But are all the mutations the same? No, it's not all the mutations the same. Depends where the mutations are allocated. So there are mutations that are immunogenics, but there are mutations that are specifically in the MHC gay caper, and these mutations are not completely immunogenics. Another important tool that we have today is the DNA repair. Seems that the DNA repair is involved in, we know that it's involved in several tumors. You have there, and I suggest to you to read this interesting paper that was published last year for the group of France in 2016. You see there in yellow, in the part of yellow diagrams, all the percentage of the DNA repairs according to the different tumors, and the percentage in blue of the response according to that with the immunotherapy. So there is an important correlation between DNA repair. We note also that the mismatch repair is also important, not only in colorectal cancer. We have nowadays in early clinical trials several new combinations coming for all the solid tumors. And you see here in red are the different tumors, in red that are the latest stage of the disease, and in blue the earliest stage of the disease. So that suggests that this is a very important tool to predict the response of our patients as well. So if we want to put all together in one slide, we can say that the pipeline for the identification of the immunorelevant neoantigens are divided in two. One is the mutational load, and the other is the neoantigen load. For the neoantigen load, we have also in consideration, we need to have in consideration the proteomic analysis, also the binding of the peptides, and also the cell recognition in the surface of the tumoral cells. These kind of things are a little bit the future, is the near future, but there are several trials coming in this direction. And finally, the new kid on the block is the microbiome. And the microbiome, this is an analysis that was performed. This is one of the examples, an analysis in melanoma patients. And according to the gut microbiome, the response are calculated, and also here you have the progression-free survival that is depending of the high, intermediate, or low proportion of the gut microbiome in the patients. So that is happening. We know in colorectal cancer, we are speaking nowadays about the fecal transplantation and other things. In lung cancer, it's still a little bit far away, but we have to thinking about that. Actually, there are two important task force, one in United States paid by NIH, and the other is by in France, that they are analyzing the milieu of these patients also in healthy population in order to recognize which one is the best option for our patients. The TILs is a long history in breast cancer. It's not my focus, but we know that the TILs in the stroma are related with a good progression-free survival in breast cancer. This is the case, for example, of triple-negative breast cancer. Actually, the data coming from the breast cancer trial, triple-negative Keynote 086, demonstrate that the patients who have a high level of TILs have a best opportunity to have an overall response rate. In lung cancer, TILs is still a far away history, but we are working on that, and we believe that these kind of tumors that are not so immunogenic like breast cancer, this kind of tool like TILs are an important tool for interpretation about the prognostic biomarkers and predictive biomarkers. In liquid biopsy, we have a very strong history in lung cancer. EGFR was the first that is having a drug approved on the liquid biopsy analysis, the osimertinib, but in the PD-L1 it's not so easy. So the history of immunotherapy is very difficult because we are working in a microenvironment. So in a microenvironment, you have several actors that are playing an important role, and PD-L1 is very naive to believe that only PD-L1 is the only one who we can catch in the blood. So the first thing that we was doing was to try to demonstrate also the mutational tumor burden, but in the blood. And this is an analysis performed in the OAC and Poplar studies, confirmed in the Poplar studies, that was presented by Gandara in ESMO this year. And you see there that according to the mutational tumor burden, if it's a higher, you have also the opportunity to have a correlation with the progression-free survival. When we complete the picture with the immunohistochemistry and the score that I told you before with atezolizumab, you see that these patients who have a high expression of the tumoral cells and infiltrating cells in the tissue, in combination with the blood mutational tumor burden, have also an important opportunity to respond. And you see here the hazard ratio and progression-free survival and an overall survival are terrific. So in conclusion, this is a very important exploratory analysis. We know that this data, the cutoff is still a little bit difficult to understand why they took 16 copies and not others. It's a great news, but it still is not applicable in the clinical trials, in the clinical practice. Another thing that we can do in the blood is to calculate the mutational burden, the hypermutation, so the quantity of variants that we have in the blood. For example, this is an analysis that was performed by the group of Rachel Kurzog in 2016, and it's a very nice paper. I suggest to you to read this in Clinical Cancer Research. The number of variants with more than 6 variants, you have there an overall response rate of 41%, compared with the variants of unknown significant, and that is, you can see in the reports of the companies, or even if you are doing a panel in your own institution. So if you have more than 3 variants with unknown significant, you have an opportunity to predict the overall response rate. If we put the data in a Kaplan-Meier curves, you see there progression-free survival and overall survival are also impacted by this hypermutated circulating tumor DNA. Another opportunity is to check the velocity that this allelic fraction variation is changing. So you have there, for example, people who have an increase or a decrease of the allelic fraction variation during the treatment. And if you see here, majority of the people who have the increase are allocated in the area of the progression disease. So if we put that in a Kaplan-Meier curve, overall survival and progression-free survival are improved when we have a decrease of the allelic fraction variation during the treatment in our patients. Obviously, the last frontier is the resistance mechanism. We know that there are several resistance mechanisms involved, including JAK mutations, and that was the first indication, but we have several others, including microbiome. So just to conclude, the take-home message for this session is we are obviously in the beginning, I can say in the beginning of this exciting journey for our patients and the research. PD-L1 is still an imperfect, but it's very necessary biomarker, and it's the only one that we have today to indicate immunotherapy in first line, and also can predict the immunotherapy in second line. Other biomarkers are improving also this opportunity, but we need to do an effort, and also we need to be very careful with our interpretations about the results. Thank you very much for your attention.
Thank you very much, Professor Christian Rolfo, and now the floor is open for questions. Please. Any question? No. Okay, I will ask a question, please, Professor Christian. My question is comparing to sequence the drugs like chemotherapy followed by immunotherapy, or immunotherapy that failed and followed by chemotherapy, versus the combinations. Is there any data?
So the idea, you mean in first line and then go for second line and so on. So the data that we have, for example, are from the trial of pembrolizumab when we have the crossover situation in the Keynote 024. And there you have an improvement also in the progression-free survival and the overall survival. So I think obviously the idea is go for first line when you have the opportunity in patients who have more than 50%, I'm referring to lung cancer, more than 50% of expression in PD-L1, I prefer obviously, and we have a strong data and robust data for go for first line. But if you have, in some cases that you receive, for example, because that's happened in our clinical practice, sometimes your PD-L1 status results are coming later and you need to start a treatment before. So if you start a chemotherapy and these patients have a high progression, expression of PD-L1, I will suggest to go for a second line with that, obviously, because you can have an important response for these patients.
Okay, any other question? Is there a correlation between the toxicity of immunotherapy and the response? Like the way we do
Yeah,
it
that
with
we have in other
therapy?
TKIs and other, there is not correlation. So,
No
and that is the good thing, because otherwise, if we need to expect that our patients are very toxic until we have a response, it's a very bad news. But we have patients that are tolerating perfectly, and we saw even complete response. So that's very important.
Can we find the correlation between the PD-L1 expression and the toxicity?
There are some data that suggest that, but it's still very weak data. So we need more data about that, and it could be interesting. I think we are not focusing a lot in toxicity, and that is a big mistake. And also, we need to be careful with the late toxicity that we will have in immunotherapy. Some of our patients are jumping from one trial to other trial, and we don't care about the toxicity, the late toxicity that we have. That is an important issue. So it's a very good question. Thank you.
Okay, so if there are no other questions, thank you very much.
Thank you very much.
Professor Christian.